Hello, my name is Deepak Kalra. I'm Clinical Professor of Health Informatics and President of the European Institute for Health Records. I would like to explain the topic of semantic interoperability and why it is important. Healthcare professionals document the health status of the patient and the treatments they provide at each clinical encounter because they are accountable for the care decisions they have taken and in order to provide the best possible information to support the ongoing care of that patient, potentially by many other healthcare professionals working at different care locations. Paper medical records have served us well until recently, but the volume of information collected at each encounter, the number of test results and other forms of investigation, and the complexity of treatments now means paper records are overloaded and difficult to navigate. It can be problematic and time-consuming to find relevant background information that could support the most effective and safest care decisions. And, of course, paper records are difficult to share within a large organization and between teams working on different sites. Electronic health records and clinical applications are growing in their sophistication and their ability to support clinicians in gaining an overview of the patient's healthcare and documenting their own findings and treatment decisions. EHRs can be linked with clinical guidelines and care pathways to help advise clinicians of the evidence they may take into account when making a care management decision. EHRs can include data from mobile devices and portable medical equipment to allow specialists to monitor their patients in remote situations. Through portable and wearable sensors, this now includes monitoring and self-management at home and during patients' daily lives. Healthcare is increasingly being personalized by using a patient's genomic information, such as biomarkers, to determine the most effective treatment for various cancers. For some conditions, it is important to track climatic and other situations in the patient's environment. Patients nowadays share health information online, often with others having the same health conditions, and this information might in the future also become part of the electronic health record and be shared with health professionals. Large-scale repositories of health information, when appropriately de-identified, can prove a valuable resource to support population health monitoring and clinical research. EHRs are therefore growing in the richness of the information they can integrate and analyze to support healthcare and research. Standards for the electronic health record need to enable us to transfer part or all of a patient's EHR between systems, or to allow an EHR system where the patient is now to generate queries and extract relevant facts from EHR systems where the patient has previously been treated. Guidelines and decision support systems, alerts, etc. need also to be able to query electronic health record information that may exist in different systems in a consistent manner in order to achieve accurate results. Personal health records managed by patients need to be able to share information with electronic health records so that patients and clinicians can work together where they need to in order to optimize the way a patient's treatment is being managed. Health services, insurers, and public health organizations need fine-grained information about health issues, health needs, treatments, and their outcomes in order to inform service planning, prevention and wellness programs, etc. Next-generation medicine, which is increasingly underpinned by genomic information, such as the patient's genetic profile, need to be able to integrate this information with EHR data in order to help determine which patients will benefit from which new generation therapies. Information standards are needed to enable this connectivity of EHR systems and the sharing of health information between them. But standardizing how health information can be communicated between systems is complicated, because clinical statements can include a lot of subtle context that has to be faithfully transferred so that the receiving system does not accidentally misinterpret the information and thereby mislead subsequent clinicians who might rely upon it. Imagine, as an example, an entry is made in an EHR system today stating a diagnosis of chronic obstructive pulmonary disease. Let's consider the different kinds of context and interpretation that might accompany this simple diagnostic statement or code and have a profound impact on its clinical meaning. The diagnosis statement might be asserting that it's been confirmed today as a result of lung function tests, or it might only be a diagnosis suspected today on the basis of a possible history. It may simply be one of several diagnoses that are being actively considered. It might only be a hypothesis written on an order for lung function tests, or it may even be a diagnosis that has been excluded today on the basis of such tests. It may be documented today because it's the probable cause of a new complication, but the lung disease is not new. It hasn't been diagnosed today. It may be the indication for giving the patient a flu vaccine. It could be the condition from which the patient's mother suffers, but the patient doesn't have it. Or it could be a risk because of a family history or a lifestyle, and again, the patient doesn't actually have the condition. Or it could be a worry that the patient has, that they might have this lung disease. It could be the coded diagnosis that's been formally documented because it has a higher reimbursement than asthma, and the patient's condition perhaps was on the borderline between COPD and asthma. Finally, it could be a data entry error that has been subsequently corrected. But of course, this historic entry will remain for legal purposes in the EHR database. Clinicians are very good at reading textual record entries and understanding these different kinds of context and using that information safely. But as we progress towards computable interpretation of the data, where guidelines, decision support systems, and other kinds of processing are interpreting the data computationally, we need this kind of context to be robustly represented in a way that is unambiguous and therefore safe, so that information can be shared across different systems and support all of those purposes I've told you about earlier. The rich detail and context of clinical information can already be captured in many EHR systems. The problem is that each of these systems handles such information differently, making it difficult to communicate. As an example, the general practice system shown here stores the cancer, the body site, the lung, and the fact that it is a suspected but not yet confirmed diagnosis as three different data items. The polyclinic system stores the cancer and that it is suspected as a single data item and separately stores the body site. The hospital stores all three concepts as a single term. When reading the slide, you can easily understand the information as being the same in all three systems. Our challenge is to develop the standards that can enable all three systems to export their data into a single format so that it can be communicated in a standardized way, irrespective of which system is exporting the data and which system needs to import it. Our challenge when developing semantic interoperability standards is the richness and breadth of coverage that an electronic health record might have in order to capture the picture of a patient as an individual and all of the interactions that different members of a healthcare team might need to have and document within an EHR. Our challenge lies in building consensus amongst all of the clinical, patient and other stakeholders who need to determine how such information needs to be structured and represented in order to meet their documentation needs and also to be able to be reused by each other in support of the care of the patient and also to support other uses of the health data such as public health and research. It is, of course, in the best interests of the patients that each discipline and each care setting prioritizes the information within its electronic health record that is most needed to deliver its specialty of healthcare. Recognizing that some diversity will inevitably exist, our standardization challenge is to identify those areas of health information that are most valuable to share across care teams to ensure the safe and effective delivery of care, and to agree amongst stakeholders on a standard way to represent that information. This is how we are seeking to achieve semantic interoperability.